I'm going to get started. My colleagues and I are pleased to extend a warm welcome to all of you. Welcome to our breakout session, Geriatric Engagement and Resource Integration in Post-Acute and Long-Term Care Facilities, specifically telemedicine and lessons learned from COVID-19. My name is Mike Curlin, and it's a privilege for the panelists and I to share and be with you here at Matrix 2021. Sessions and discussions like this are especially important now in a time where most of us in the country are still learning how to use telehealth, especially for our most frail and elderly population. Healthcare operations and decisions matter more than ever now for each of us individually, for our clinicians that we work with, and the people that they take care of. I'll be moderating this session, and we understand, especially by now, you might be suffering from a full-blown case of ZVS, clinically known as Zoom fatigue syndrome. To the non-clinicians, administrators, vendors in the session, it's commonly known as boredom. That's why we want you to ask questions and just comment, give folks your opinion. In fact, if you're not driving your kids somewhere right now or picking up groceries, and if you're really at your desk listening, tell us like what state you're in, the organization you're from, just drop it in the chat. And in case you miss anything that we cover in this agenda here, don't worry, this is being recorded so you can watch and watch and watch and listen to it as many times as you like. Today, I have the pleasure of sharing the platform with the University of Virginia's finest, Dr. Lori Archbold-Pannoni from UVA Geriatrics and Infectious Disease, Dr. Justin Mutter from UVA Geriatrics, and Dr. Kimberly Albero from UVA Project Echo. By the way, it's a summit tradition to not read speaker bios as part of the intro. I know many of you are probably disappointed that we're not going to do that. We're going to get right into it. But in case you don't want to take my word that these are awesome individuals and professionals, you have their information in the event platform. Each speaker is going to present, and then we're going to do a Q&A. So please do add your questions as you think of them. Don't save them to the end. As you think of them, this way I have time, and some of us have time to kind of like think of the answer and maybe just weave it into the presentation. So at this moment, I'd like to pass the baton over to Dr. Lori Archbold-Pannoni.
Thank you so much. Thank you all for joining us today. Let me go ahead and share my screen. Well, thank you all for joining us today. We're going to be talking about our experience with implementation of telemedicine in our regional post-acute and long-term care facilities, some of the lessons that we've learned from the past year with COVID, and some of the lessons that we take forward, hopefully moving to the post-COVID era at some points. So there, as speakers, we have no relevant financial disclosures. These are our learning objectives for the day, which you can review. And with that, I'll pass it to Dr. Mutter. Justin.
All right. Thank you, Laurie. So like many people all across the Mid-Atlantic region and beyond, of course, in sort of the early phase of the pandemic, we were looking at very concerning situation in long-term care and trying to understand how we could engage with local and regional long-term care and post-acute care facilities, particularly thinking about the role of telehealth in that environment. And there have been, as we all know, lots of studies that have been published about vulnerable populations, not just in facilities, but what sort of medical and psychosocial conditions are potentially modifiable in the context of COVID morbidity and mortality. But one of the things we really were trying to figure out is what are the systems-based approaches to trying to alleviate the impact of COVID in any given facility, in any given long-term care or post-acute care environment. Next slide. So as we all know, COVID-19 has been absolutely devastating for the vulnerable older adult population in long-term care and in post-acute care. We were certainly seeing this early on in the state of Virginia. And early in the pandemic, as we all probably know, about 40 to 50% of all deaths were in those facility dwelling populations. Now that has decreased a little bit to around 1/3 nationally. And of course, there's variation across states and across localities. But that's less than 6% of all cases nationally were in long-term care and post-acute care. And then that's less than 1% of the population. So dramatic statistics in this regard in terms of the impact overall. And thankfully, starting, it seems around February, we are seeing a substantial drop in deaths. But much of what we're going to talk about today regards our interventions at sort of early to mid-pandemic and the local and regional facilities where we partnered. So, so when we think about telehealth in particular and how it relates to this population, particularly in the context of the COVID pandemic, we felt like it was absolutely critical to, number one, know our facilities. And as many of you are probably aware, and some of you very, very much part of your daily work, facilities are very different. There are lots of different subtypes of facilities. There are lots of different arrangements for how clinical care is provided, either on-site or off-site with regard to facility residents. And so one of the critical things that you'll see us talk about today is how do we orient systems-based interventions for telehealth around particular facility needs and particular facility environments. So, oh, back one more.
Oh, sorry.
And so this is just, I'm not going to go through all this list. Many of us are probably familiar with some of the differences between some of these facilities, but just as an example, taking assisted living, in many assisted living facilities, care could be provided on site. Some assisted living facilities may have a medical director, they may not. Others may get most of their medical care offsite. And of course, the pandemic very much problematized a lot of that provision of medical care. And so thinking about each individual subtype of facility, each arrangement, are they part of a large nonprofit chain? Are they a single facility in your environment that doesn't have resources outside of their particular locality? All those things are very important for our interventions.
Thank you. So understanding our different facilities, the different types that we have regionally, the different types of patients that are in the different facilities. In, about a year ago in early March, as we were going into the COVID era, we were seeing a lot of medical limitations in terms of how care would typically be provided that were arising with the changes in obviously free flow of where we go and how we go. There are many limitations in facilities, limiting residents even leaving the facility, going to doctor's appointments or anything outside of the facility was limited, or residents were going, they may have to quarantine on return. There were limitations on visitors coming in, even medical teams coming in. This early in the pandemic, as primary care providers or even hospice providers, there were times when even the medical teams weren't allowed to be inside the facility physically. For our residents, there were changes in available transportation. So there may be transportation options historically that with COVID or with COVID coming were no longer available to residents because of infection control concerns. The large buses perhaps from the facility would have that could take people around the community and bring them to doctor's appointments or other places around the community weren't available. And some of the outside transportation providers were not providing transportation for the residents either. Especially in our assisted living facility residents, this could have great impact on not just their day-to-day social activities, but also their medical care. So limiting their access to the medical team, or even limiting their access to be able to get their prescriptions filled to get to the pharmacy. And so there were a lot of medical limitations that we were facing, and we really needed to come up with some quick and creative solutions to be able to ensure that our patients were getting proper and adequate care. So some of the types of things we needed to think through, and again, nobody had the answers, right? Nobody had done this before. None of us knew, we didn't have the evidence to support what we were doing based on previous studies. And so we really had to be creative, start to think on the fly, think about what the goals were and how we could create solutions to help to mitigate these limitations. So really focusing on care coordination across sites to ensure that the medical teams, the clinical teams in the facility, in the clinics, in the hospitals, in primary care, and subspecialty care clinics had coordination. And so we were all opening communication, which ideally is always there, but even more so opening communication with each other to ensure that we're all providing care for our patients. We strove to work very closely with our regional facilities, ensuring that, our facilities had the proper PPE and supplies. As many of you recall, a year ago at this point, there was so much changing on a day-to-day basis in terms of what was needed, what the proper recommendations were, and then being able to access those. Were they cloth masks? Were they N95s? Where were the gowns? Where were the gloves? How do we do this? And so working with some of the resources that we had as a university center, but also within our community to integrate a lot of the volunteer or community-based organizations to be able to coordinate with our facilities to help to get them the supplies they needed. We also wanted to provide assistance in terms of infection control and prevention. Again, this was a new era for all of us, right? We knew the infection control tenets. We knew what works in terms of infection control and prevention, but how are we going to implement this on such a wide scale with the overall guidelines coming out nationally, regionally, locally, per corporation, per facility, but also how was a facility going to implement that in their particular building? And so how could we collaborate, work with our regional partners with both sharing education as information was coming out, as well as sharing best practices within our community when we were developing ways to do things in different facilities to ensure that there was a way to get that shared across the community. And so these were kind of leading to some of our guiding principles for the program that we developed in March of 2020, just about a year ago, which we termed GERI-PaL, and we'll talk a little bit more about that. And so some of the guiding principles that we had from the outset of our program were to create a system to optimize the response for COVID outreach with our post-acute long-term care facilities. And we knew that this really needed to take an interprofessional team. We needed to engage partners across the care continuum to ensure that we were coming up with creative solutions that would encompass all of the professions involved. We needed to sustain communication between partners and really further develop relationships, focus on relationship building, working together, and ways to communicate freely so that we understood both the needs as well as moving forward together. We knew, with outbreaks kind of on the horizon or outbreaks coming, that we needed to establish as much as possible a systematic approach to integrated patient care, that our patients had the potential to become very sick very quickly, and we needed to put systems in place to ideally recognize this early and provide optimal care. And again, that we didn't have the answers. We didn't know what was going to be best. And so we really had to develop a model of adaptability and reflexive innovation to be able to, in real time, adjust based on the needs of the situation as it arose.
So, and this is from one of our earliest publications in terms of thinking about one of our interventions at one particular facility. But as you can see here in this slide, one of the big questions was then, how do we translate those principles into practices and into processes that we were engaging with each individual facility. Again, keeping in mind also the need for reflexive change and innovation and adaptation as we went along. And there were about 5 key components, and Laurie will sort of unpack each of these as we go along. But as you can see, some of these were really important early in the process of engaging with the facility. Some of these were important throughout the process. And so really it took all of these different 5 components and efforts to engage across time. And this is just a few of our qualitative outcomes from a couple of our publications, and I won't go, excuse me, quantitative, and I won't go through all of these, but we, in most cases for the facilities with which we had strong participation, we did experience quite significant numbers of uptake for our telemedicine consults, which we'll talk about. And thankfully, both hospitalization rates and mortality rates were lower than the national average at that time in most of our facilities where we participated.
So what is this GERI-PaL program and how does telemedicine fit in is really will be our focus as we move forward. So GERI-PaL is the name that we came up with to describe the intervention that we were putting together. And it stands for Geriatric Engagement Resource Integration for our post-acute and long-term care facilities, to highlight the purpose and the goals of our program as stated, that we really wanted to engage the community at large and to bring together resources for our facilities to help support them through these uncertain times. So we had generally 2 arms of our GERI-PaL initiative. We had our COVID prevention arm as well as our COVID outbreak and response arm. So in our COVID prevention arm, we started this by mid-March of 2020. And we started first with a Project ECHO series, which Kim will talk about in more detail. We established the role of a nurse liaison to connect directly with facilities, which we'll talk a little bit more about. We offered infection control advisory consultations, so one-on-one with the specific facility and their staff, their administration, to talk about the infection control implementation challenges or issues, barriers that they may have in their facilities. We paired residents with our local medical students to help to establish social connections over the phone to decrease or try to limit social isolation. And with this integrated program had telemedicine as a component, which we'll talk about how that fit in there. So with that, Kim, do you want to talk about our Project ECHO?
Absolutely. Thank you so much, Laurie. Project ECHO is an international program. It was started at the University of New Mexico, and the intention of Project ECHO is to disseminate best practices and democratize medical knowledge. ECHO in this case stands for Extension of Community Healthcare Outcomes. And in this case, rather than providing information to the providers who were taking care of the residents in the long-term care facilities, we first started with the staff at the long-term care facilities. We invited the directors of nursing, the nurses and infection control nurses to join us for, in the beginning, I think our first one was March 16th. So we were about a week out from the pandemic being declared a national emergency. We started to just disseminate what we knew to be the recommendations and the guidelines, and then spent a lot of time listening to the staff, listening to their concerns, and then helping to answer questions. In the time in between sessions, we would find resources and we would connect people with resources. So we started with just kind of a daily overview of the situation in the state, to include case data and information about testing and mostly about the PPE, the personal protective equipment, because we had the community had a large response to say, we have things we want to get to people. We can make face shields, we have supplies, but we have no way to know where they are needed. And so our response effort was driven by both knowing that there were certain supplies that were available, and also that we knew where they were most needed based on our conversations with the facilities that were on these calls. And we also engaged with the local fire department to find out, from their side, what they knew about the conditions in the other facilities that maybe had not yet been contacted or engaged with Project ECHO. So each of the sessions that we held had that infection control component, an update on clinical guidelines. And at the time, I don't know if you'll remember back to then, there wasn't a lot of information. We were figuring out what the symptoms look like and what to expect in older populations. And I believe that the outbreak at the facility in Washington, which sort of was the most that we knew about how this looked in nursing home settings where communal living was, part of the deal and part of how transmission was occurring. And that really, as we read and heard and listened to our colleagues, we were able to make recommendations about what to do in terms of cohorting patients, keeping patients out of settings like the communal dining area where a transmission could occur. And we also spent a lot of time reassuring the staff that they were heard and that their input was really meaningful and was affecting change in the state. In this case, the topics were very COVID focused, but the response we got, especially kind of just offline in conversations after the sessions, was appreciation for the connection to other folks who are doing similar work in similar settings. And one thing I always like to remind people is that, while folks not in healthcare were trying to figure out which bread recipe to try next and, ordering their exercise bikes, these folks were going to work every day and they were going to work in places where infections could occur and were occurring, and they needed help and support just to figure out how to do it correctly, and how to protect themselves as well as the residents. I think the next slide talks a little bit about correct me if I'm wrong here, about the nurse liaison role. Yes. Yep. So in this setting, we had a single nurse that was responsible for, took on the responsibility. She sort of invented her own role here. She was coordinating with both the community-based resources through the local fire department, as well as talking to the directors of nursing at each of the facilities. She would let them know about the Project ECHO series and the fact that they could join that. And then she also would, spend some time asking about the concerns that they were having, as we sort of figured out where there could be outbreaks or where outbreaks were happening and what the needs of the facilities were. She was also instrumental in integrating the telehealth resources. So she was the one who did training on the devices that were used to do the telemedicine encounters. She trained the staff there. And then she also found she would bring back the feedback from the facilities to let folks know that this particular device, because it relies on Wi-Fi, doesn't work in this particular part of this particular facility. And so she was really able to drill down onto some of the the technical issues with the actual equipment, and which really helped us to figure out what the best way to deliver care through telemedicine was. And her role was really critical in finding those answers and providing some recommendations for how to innovate, how to fix the problem or work around the problem, and then also how to optimize the use of those peripherals and the telemedicine equipment that we were able to bring into some of these facilities.
Great, thank you, Kim, for describing that. And to use an example of one of our first initiatives that we were able to successfully implement in terms of, how did we put this into practice? How did we, make change through this system? Through our Project ECHO series, which we were hearing from our community partners at various facilities, and our nurse liaison who was connecting, more individually with facilities as well. One of the issues that kept arising was testing patients in facilities for COVID-19. And as I'm sure we all recall, testing, especially early in the pandemic in March and April, was very challenging. Getting access to testing supplies was challenging, and getting a quick turnaround on the results of that test was very challenging. And in our region in March, certainly in early March, the test needed to be sent out to an outside lab, and it could take up to 7 to 10 days to get that result back. And during that 7 to 10 day time, the resident is under isolation, as would be appropriate, and the staff is needing to utilize the necessary, the highest level of PPE and precautions to ensure that if that patient is in fact infected, that they're not spreading that infection to either themselves or the other residents. So that means that they're using N95 masks, which were in limited supply, and they're, using the gowns and gloves. And they're doing that for the entire week or 10 days as we're waiting for the test result to come back. And if it was ultimately negative, perhaps that was time that we could save that excess PPE, that we could save those N95s if they weren't in fact needed. And so we worked with in a listen first model, heard that from our facilities that this was really a major issue for them because they were having limited PPE, limited staffing, and it was taking so long to get the test results back. In addition, facilities didn't always have the testing kit on site. And they didn't know how to access that. They didn't know how to perform the test properly. And they just needed help with getting the test to the facility to test the resident. Otherwise, they were going to have to actually send the resident out to get testing, which is not ideal for many reasons. So hearing this concern very early, in our Project ECHO sessions and through our nurse liaison, we again worked to integrate our resources to discuss with our local health department, with our local, our UVA clinical micro laboratory to really explore what are our options, what could we build, what could we do to help support our facilities with this issue. We're fortunate by about March 19th that the UVA clinical micro laboratory was able to stand up local testing for COVID-19. They were able to get FDA approval to test on site, and were very innovative, even at some point getting permission to develop their own swabs when those were in limited supply. So we had access to a wonderful testing site that saw the need to test, to prioritize testing in our long-term care and post-acute facilities, in our most vulnerable residents, as well as to have a rapid turnaround time. So they were willing to support the testing and could get the result back within 48 hours initially, and ultimately 24 hours. We were then able to coordinate with our local health department to bring everyone together to talk about this need, and the health department was able to deliver the kit on site at the facility when needed, to work to coordinate carrying that kit once done to the laboratory, and then we could all work together in terms of reporting the results and helping the facility to care for residents who may ultimately be positive or under investigation. And then this ultimately grew into point prevalence surveys where we're doing the whole facility to help facilitate that. So that was one of our first interventions that we had, again, that was based on the listen first approach of Project ECHO and the nurse liaison, hearing the concerns of the facility, and then bringing together the community partners who were able to assist to develop a new system for testing. So where does telemedicine fit into all of this, right? So we're talking about kind of multiple components of our initiative. And one of the components was, of course, our telemedicine consultation. So, so with our GERI-PaL program, we had our Project ECHO series where we're hearing concerns and building community. We had our nurse liaison that was furthering those relationships and understanding. And then we had the opportunity to implement telemedicine consultation for our regional partners, our regional facilities. And we had 2 services that we were able to provide initially. We had pulmonary and critical care colleagues who could provide COVID-19 specific care and oversight. And then we had geriatrics and palliative care that could do consultation as well. These were often deployed in well, we did have the prevention arm, so we could do those from a prevention standpoint, but most commonly we were deployed in an outbreak setting. So if a facility had an outbreak or that was starting or was occurring, then we would often hear either through Project ECHO, through our community partners, the facility themselves, that they're having concerns and doing testing and had positive cases. And so in connection with them, we were able to, if they agreed, we're able to rapidly deploy what we called our COVID kit. We first put contracting in place to allow us within about 24 hours to be able to provide care via telemedicine consultation in the facility, and then deploy the COVID kit, in which team members would bring out the tablet with the audiovisual app, as well as a virtual stethoscope, to be able to provide the services of the telemedicine virtual visit. The education on how to use this kit was done through our nurse liaison role. And so she would hold sessions virtually, often on Zoom or on a similar HIPAA compliant platform like WebEx, and educate the staff on how to use the device. They're relatively straightforward, as many of you probably know, but it's important to know exactly how to use that. One of the limitations we'll talk about a little bit later in more detail. One of the limitations in an outbreak setting is staffing. So staffing in a facility can be challenging on a good day. And once we get to an outbreak setting, we can have staff that are under investigation, that are sick because that they're waiting for their test result to come back, they're ill, they're out sick, or they choose not to come back. And so staffing can be a limitation. So we would train the staff to perform the telemedicine visits, to be the telepresenter. But we're very flexible in who that staff member could be as a telepresenter. Ideally, that would be the nurse who knows the patient well and could participate in the visit, but understanding that the nurses were needed for many roles within the facility, and there are a lot of patients that were quite ill, that any staff member who was able to be trained in the telemedicine device could be the telepresenter. It did not take a clinical background to be the telepresenter, because on the other end of that would be our physician who could say, put the virtual stethoscope here, put this here, and walk them through the visit so that that could free up the clinical members of the staff. And so we would have, perhaps the marketing person or the front office staff who'd be willing to go into the patient's room to be the telepresenter and allow the clinical staff to do on-site care. So for the outbreaks of the facilities that we worked with, the way that we would identify patients who would most benefit from a telemedicine consult was through a system that we refer to as our virtual daily rounds. So taking the idea of daily rounding that would often be done in the hospital on acutely ill patients, transferring that to our facilities, we implemented virtual daily rounds, which were virtual. They were done via a HIPAA compliant audiovisual platform, which you could also call in if the facility didn't have access to if it was easier for them to do it on the phone. And the purpose of the virtual daily rounds were to, at first identify potential outbreaks, facilitate testing. We would get the technology quickly, and then create a system for that systematic approach to care of the patient, with the goals being having an efficient way of facilitating communication. As any of you who've experienced an outbreak in a facility know, or as you can imagine, things can get pretty chaotic pretty quickly. There's a lot going on when you're at the beginning of an outbreak. And in an outbreak, there's a lot of moving parts. There are a lot of things that need to be done. And so the staff is quite, there's a lot going on. The staff can be overwhelmed pretty quickly. And so you really need to make anything that's going to be done as efficient as possible. So what we would do with these rounds is bring together all of the decision makers. We would have the director of nursing. We would have the the on-site care team. We would have the licensed independent practitioners, the MDs, the NPs, the PAs that were taking care of the patients. And we would have our team all there at the same time to be able to have this discussion on the patients and make these decisions. The alternative would be that the nursing staff would have to call each individual practitioner about their individual patient, and that could take much longer. And so bringing everyone together for one meeting was the most efficient way to do that. The way that we would then do these daily rounds is the first part of that, even before rounds, the nursing staff would collect vital signs on all of the either patients under investigation or patients with COVID infection. They would collect vital signs and send that to our team with our critical care physician, and we would review those vital signs to identify patients that may have a subtle clinical decline. So we would review those vital signs. We would all meet together on virtual daily rounds. We would first go through, who is the nursing staff concerned about. We would help with care escalation if needed, transfer to the hospital, transfer back from the hospital, and then again, rapidly and efficiently identify patients who may be appropriate for a specific COVID consultation. We'll talk a little bit more about that. So a couple of points about our virtual daily rounds. It sounds like a lot, right? We're talking about bringing all these parties together. We're talking about going over vital signs and talking about all the patients. All of our virtual daily rounds, and even when we're talking about some of our larger outbreaks, which could be 50 or even 80 or so patients that we're reviewing, all of our rounds were always 30 minutes or less, understanding that the staff was very busy and had a lot to do in taking care of these very ill patients. And so we really needed to be as efficient as possible. Again, we had all the decision makers on the call together. We would review the vital signs and talk about any patients of concern that the nursing staff had overnight. We would then also review the in-hospital course. So patients that had been sent from the facility to the hospital, that can often be a bit of a black box for facilities. They may not know the hospital course of their residents that are sent to the hospital until they get that call, the person's ready to come back. In the COVID era, there's a lot of coordination that's needed when that patient's ready to come back, right? Is there transportation? Is there staffing? What's the cohorting situation? When can they, safely take that patient back? And so being able to keep up to date with what the course of their residents in the hospital was very important. And so our team was able to be in close contact with the hospital-based team to be able to give reports, for example, of the 5 patients from your facility that are in the hospital, these 2 are still on the ventilator. This person has been extubated, but is still on high levels of oxygen, and these 2 people are, weaning off oxygen onto room air. Perhaps they would be ready to come back in 2 or 3 days to give, some lead time for facilities to be able to plan for that and to be able to coordinate with the hospital for, when they're realistically able to accept these patients back. Perhaps the hospital would say, this patient's going to be ready to go tomorrow. And the facility might say, look, we can't maintain staffing for a new admission at 7 o'clock on a Sunday night. It's just not realistic. It's not safe. If you could hold that patient until Monday morning, we'll have adequate staffing to be able to accept that patient back. So being able to coordinate that transfer was very helpful in terms of transfer out of the hospital. We were also help to coordinate the transfers to the hospital. So if our physician, one of our physicians was able to do a telemedicine consultation for the patient in the facility and deemed that they needed to be transferred to the hospital, in the beginning, we were able to actually coordinate direct admissions. If that patient clearly needed to go to the ICU, they'd already been evaluated via telemedicine by an ICU physician, then we could work to coordinate that direct transfer and hopefully bypass the emergency department. as the cases picked up more and more, and the numbers just became, it became not possible to be able to do direct admissions in that way, but that was something we were able to do in the beginning. And through all of this, we were able to identify the residents who would benefit from the telemedicine consultation. And these were the parameters that we would use in those review of the rounds and review of each patient to identify, the potential for subtle clinical decline. For those of you who aren't providers, just to say in brief, COVID-19 infection is, as we've learned, more complicated than a lot of the other infections that we are used to taking care of. And so the numbers, the vital sign flags, if you will, to say this is of concern are different for COVID than for other infections. And so, we would print out this chart. Every nurse would have that on their cart. They would have that with them. They would kind of start to learn what the new numbers were for COVID infections versus other infections and other markers of subtle changes in these patients, which could represent, that a clinical decline was coming soon. And then these are the patients that we would identify to be seen by our pulmonary critical care colleagues. So as an example of one of the facilities that we worked with closely and implemented virtual daily rounds, that outbreak remained active for about 6 weeks. 82 or 60% of the residents in the facility ultimately were infected with COVID-19. 70% were able to remain in the facility for treatment. 21 patients ultimately died from their infection, 10 in the facility and 11 in the hospital. 36 of the patients that were positive were seen by our telemedicine consultation team, and 70% of them were able to remain with treatment in place, so they did not require transfer to the facility. With goal concordant care and assistance and oversight from our pulmonary critical care team, they were able to remain in the facility as was in keeping with their wishes for their care. And these hospitalization mortality rates were lower than similar outbreaks reported, especially early on in the pandemic. So this is just a bit of an overview on the process again, the specific agenda that we would use for the virtual daily rounds, and then the participants who were on each of the calls. So in summary, from our COVID response, we had with this integrated program, of which telemedicine was a component, we were able to show that the facilities we worked with had a lower mortality rate, lower hospitalization rate than others reported. And they were, the components were well received by participating facilities. We'll talk a little bit more about that. Some of the key innovation components of our implementation program were the interprofessional team. Again, we talked about that being one of our goals initially. We had physicians, nurses, our EMS and public health community-based resources were working very closely together, often on our daily or frequent Project ECHO sessions. And the multidisciplinary experts that we were able to bring together really allowed us to more fully assess the needs and really adapt to meet the real-time needs of the facility. A key challenge that we identified, and an ongoing challenge, is that requiring a telepresenter in the room is additional work for the on-site staff, the facility staff. And so how do we help to offload some of that is something that we'll need to kind of figure out the nuance of moving forward.
Lori, can I just speak to that for a moment?
Yeah, absolutely.
Just to touch on the, what we learned from the virtual rounds as well as the Project ECHO intervention, there was one instance where we found out that the process in place was for the facility to send a printed chart with the patients who were being transferred to the hospital, to UVA, and in the process, and this was in the beginning when some of those patients were going through the emergency room, the chart was discarded because it was considered to be contaminated because it had come from a COVID positive clinic with a COVID positive person. And so rather than have the papers in hand, the nursing staff who ended up accepting those patients either onto the ward or into the ICU didn't have any information, didn't have their medication list, needed to do a med reconciliation as soon as those patients arrived. And so those nurses were calling the facility and asking to have these documents faxed over. And so in addition to handling as many patients as they needed to care for in the facility, they had this additional administrative burden that was really hard to respond to. So one of the things that we were able to do, the nurse liaison, myself, Lori, we spoke with the head of nursing at UVA, and we said, can we come up with a better way? Can we fix this at UVA so that we're not adding to the administrative work that needs to be done in these facilities? Can we coordinate some way that every single nurse who's taking care of every single patient isn't calling multiple times? And we did. We found a way to integrate an e-fax documentation from the facility into the care as an attachment to the chart that was created at UVA. And we also found some workarounds for creating patient records because of testing that had been done previously that was processed through the lab. So, we listened very closely, and then we responded very specifically to fix some problems that ended up making a big difference for the staff at the facilities.
Great points. Thank you, Kim. So just to, kind of summarize some of that, some of the key lessons that we learned, a bit of an understatement, but to say it nonetheless, COVID-19 is complicated, right? It's complicated our lives, it's complicated our care, it's complicated life living and working in our facilities. We've learned a lot over this past year, and we still have much to learn moving forward. One of the things that we've learned is that outbreaks in facilities are not inevitable. If there's a patient with COVID-19 in a facility, it's not inevitable that everyone in the facility gets COVID, right? Infection control works. Infection control and prevention can work when done well. And so outbreaks are not inevitable, and devastating outbreaks are not inevitable. There are things that we can do to mitigate the factors of infection control and to prevent spread. In addition, telemedicine we utilized within the context of our program. It was a great tool. In some cases, it can be very beneficial and very helpful in being able to access patients that aren't able to access in other ways, to be able to provide subspecialty care in the facility without having to transport out of the facility, but not alone. It didn't stand alone. We used it within the context of our larger program and had the program to be able to both establish relationships with facilities, identify patients that may benefit from telemedicine, and then use that tool when it was the right tool to be used. Again, the benefits, we could do a quick assessment and have shared decision-making, especially when on-site care was limited. And the challenges, as we mentioned, were the staffing for each visit when staffing may already be limited in the facility. The integrated communication is essential, being able to discuss, as a care community, kind of globally, as well as specifically in care of individual patients, to ensure that communication, whether that be medical records, whether that be transfers, out of the hospital, is integrated, streamlined as possible, and really working together as a care community is key. So some of the lessons learned and moving forward that we've gleaned from our work over the past year. For primary care providers, who take care of patients in facilities, to know who's in the facilities and where they live. As Justin mentioned earlier, there are a lot of different types of facilities, and we can often, kind of use terms like long-term care facilities or nursing homes or different kind of global terms, which actually encompass a lot of different facilities. And so really understanding the differences in scope, the differences in purpose of different facilities, as well as the difference in staffing and clinical care abilities, is important to know the facilities that you're dealing with. obviously know the process for COVID and COVID infection and prevention in the facility, as well as the history and policy on telemedicine in the facility is important to understand and be proactive in making these connections. Similar for hospital systems, to really be able to integrate well with the community to coordinate care. And again, for all of us, we're working as a care community to work together to provide the best care for our patients, especially the most vulnerable for poor outcomes from COVID infection. So with that, Justin, you want to talk about some of the qualitative outcomes?
Yeah, just wanted to mention, we've talked a lot about the quantitative outcomes, but as Kim and Laurie have mentioned, there's so much in the background going on in terms of relationship building with different facilities and team members in those facilities. And so we did, through the efforts of the nurse liaison, especially sustain contact with the partnerships that we had with these facilities and solicit their feedback. And these are just some of the comments that were received. And I know somebody in the chat wrote about, well, how do we go forward with some of this? What's the impact? And we'll certainly get to that. But the first comment here is, certainly to that point that we really should keep this in place without COVID, that people who did participate with us really felt like there was a system in place which was meaningful, not just for the moment, but also going forward for all kinds of different care needs that vulnerable populations have. And so we were pleased to have some of those qualitative feedback sessions as well.
Great. Thank you. So with that, we have, some representatives from our team, which are great team members, but we had a much larger team that we work with to make this possible. We, in addition to our UVA-based team, we had great community partners that were very engaged in the care of our patients in our community through our health department, through our long-term care ombudsman, and again, through our EMS service as well. Our clinical micro lab was very supportive. Our institution and the Center for Telehealth was integral, as well as Matrix, and working closely with our statewide health department and long-term care facility task force. So we couldn't have done it without all of them and many more. So there are some of our resources on some of our publications. And with that, I'll stop sharing my screen and we will turn it over to discussion.
Excellent. Thank you very much for that informative discussion. All right, folks, we have a series of questions in the chat box. I'm going to try to summarize a few of them. A couple of last ones, and I know everyone is always interested in this because it gets right to the bottom line. Maybe Justin, if you could kind of give us a little bit more about like what's the reimbursement structure for telemedicine and telehealth in the post-acute and long-term care communities, and maybe if you can compare it to what's in other communities like just PCP and clinic, so folks can have like an understanding of the differences.
Yeah, so in terms of our program, the only aspects of our care for which we were reimbursed were the actual telemedicine consults that were done. And so in that context, there was an clear documentation of the provider-patient encounter. There was a bill submitted, et cetera. And somebody else asked about the contractual processes for that and the organization of the partnership. And so just to speak to that, since that relates to funding and billing, none of these facilities were UVA-owned facilities. We don't have any UVA-owned facilities actually in our network. And so these were partnerships. And early in the process, we worked very closely with our legal team to create a contractual process that could be developed and deployed very quickly so that we could have those early conversations. If say there was an outbreak setting going on with a facility, we could have those early conversations with facility leadership and be able to deploy a contract that would be signed in a matter of 24 hours. At the same time, we're trying to deploy the virtual kit. And so that did set the stage for being able to have, formal partnerships and everything being HIPAA compliant, et cetera, to be able to, when we did have a formal assessment of a patient, that we did bill on that side. That being said, there was a lot, as Laurie and Kim have discussed, that was going on behind the scenes. That was relationship building, community building, infection control, virtual daily rounds, et cetera, et cetera. And that was more a just do it kind of approach. That we were grateful to have the Center for Telehealth at UVA to be a extremely strong partner, and multiple other strong partners at our institution and in our community. And we really just focus on making it work in a challenging time. And so that was the sort of basic structure. I think somebody asked, what did you bill? Under guidelines, we could have billed domiciliary codes for, depending on what the nature of the facility was. And sometimes we did have to work with our coding team members to make sure we were getting that right.
And Mike, also just to note, there was some CARES Act funding that supported the Project ECHO series and some of the other roles, the nurse liaison role, which did not previously exist until this moment in time when COVID showed the need for it. But I think one of the things that allowed us to have the kind of administrative support from the hospital and from the health system and community that we had was the idea that this was adding value, in that if you think of value as outcomes over cost, we were saving lives and money by helping to provide a setting in which the staff felt comfortable treating patients in place at some of these facilities. We were trying to prevent any unnecessary transfers and really keep aligned that goal concordant care. We didn't want to transfer someone who, had a terminal illness and was prepared to transition to hospice care. But we were able to help to coordinate some of those decisions, some of the, thought process that went into it. And we also we never took over the care of the patients unless they needed to be transferred and needed that escalation of care. We were supportive. We were supportive of the LIPs that were responsible for writing the orders, and were very helpful in coordinating. I saw there's another question about consent, coordinating the communication between the patient or the proxy, and getting that consent, sometimes over the phone, sometimes we had some forms that we created to really outline what the scope and limitations of the consults would be, and how that was going to play into the care delivery that the staff and the LIPs were already used to in that setting.
Thank you. As you were asking that, answering that, another question was popped into my head. Sorry, folks. Speaking about limitations, it's and I know I key in on that, but what about can you speak to some of the limitations for facilities who were not able to implement telehealth? Can you just kind of talk about that?
Yeah. So I think, if we focus on outbreak settings, so the facilities that, were having an outbreak and were not able to implement the telehealth component, some of the main limitations were often staffing, right? Or the perception of staffing limitations. And so, it did require early on, pulling together a meeting with administrators and our team to talk about, what this could look like, what this would be. And in an outbreak setting, some facilities just quite frankly didn't have the time to do that. Even if it was going to be a brief meeting, there was just so much going on that they just didn't have time to do that, or didn't perceive the time to do that. So staffing, so even kind of getting that initial meeting may have been a limitation, as well as feeling cautious to not burden their staff with something new in such a complex time. So kind of feeling like, wow, this sounds great, but I just don't know if we could, take the 20 minutes to train the staff on how to be a telepresenter, or, kind of implement a new system while everything is so different, were some of the limitations that that facilities would express to us when that we weren't able to kind of move forward with the whole program. That said, those are also some of the limitations that some of the facilities that we did ultimately work with would have in the beginning. And, we're willing to kind of talk through, and many of the facilities that we worked with would, at the end of it, kind of when things would lull down, the outbreaks would go away, would say things like, wow, I wish we had implemented virtual rounds sooner, because they sound daunting at the outset, to bring this new system in place and to bring everybody together and have these discussions. But being that they were systematic and we were able to keep it under 30 minutes, they were actually more efficient ultimately, and provided kind of offloaded a lot of the work that the staff would have to do in coordinating with people. So, but staffing was a major limitation. And one of the questions also mentioned the use of the nurse liaison as the telepresenter, which I think is a great idea, in a non-outbreak setting, to be able to deploy our own team members to be telepresenters. Some of the limitations with our specific initiative for that were the facility lockdown in early outbreaks and early pandemic, right? Nobody was allowed in the facilities if you weren't critical staff, and so they really wouldn't allow additional people into the facility, was one limitation. And for our specific program, we worked with a lot of, we worked regionally. We had quite a large catchment area with a lot of more rural setting facilities. So the kind of physical reach of being able to send one person to multiple facilities was just kind of not a realistic ability that we had to be able to get people on site. Moving forward, though, I think with a program like this, to be able to solve that issue of having the staff kind of locked in, so to speak, as a telepresenter, would be a big point to work through. And if we were able to deploy our own team members, I think that would be a great way to do that.
One other limitation, Lori, was the connectivity. Some of these facilities that were out in rural areas didn't have the broadband, and the devices that we were using required Wi-Fi to be able to connect the device to the peripheral device to the iPad, and then to send those images and encounters over. So, and even in very well, even in some of the facilities that were in the middle of town and very well connected through to the internet, there were still issues within the building of connecting to Wi-Fi. So, that was one of the things that, as we were advising about maybe having a dedicated COVID wing, so that we could, help the facility to make decisions about where to put patients who were COVID positive. We found that sometimes they'd move them to a wing that didn't have good Wi-Fi, and so the patients that needed that care through telemedicine were not able to get it because of the internal structure and some of the limitations. And it wasn't something that they may have known it, they may have realized that like cell phones didn't work when they were in a particular part of the building, but it wasn't something that was impacting patient care until we deployed the telemedicine technology. So it was definitely a good learning point, and a good thing to investigate before a device or a platform is deployed to a facility. Is there a workaround if there's not good broadband or Wi-Fi? And is there a particular part of the building that should be where these visits occur?
Yeah.
Thank you.
Well, I was just going to say, and to that point, we also had great support from our technical team that would be on site to deploy the device. And while they may not be able to get into the facility, could at least kind of stay outside or on site while the staff may be able to try it at different parts of the facility, and then be able in real time to be able to troubleshoot if technical issues occurred.
Gotcha. So that actually leads into like two other kind of questions. Like you mentioned some of the challenges of like deploying and kind of like taking care of this elderly and frail population. But if you're looking like and this question comes from Chris Budding, if you're looking post-COVID, like, what are some of the other challenges with this population and using telehealth? Do you kind of foresee, like, what was this tipping point and your experience leading you to kind of like, all right, post-COVID, we're going to need to definitely address?
So I can jump in. I'm sure Laurie and Kim have other thoughts as well, but and I'll channel something that Tim said in the chat here, just about how there's still so many barriers to various populations and various aspects of medical care accepting telehealth as a modality, as a strategy within a larger effort. And I think certainly to the points made earlier, staffing remains just a huge challenge. And in order to create processes that are seamless with telehealth, figuring out the staffing issues are critical. I mean, I'm sure many who have provided care via telehealth to facilities across the country would say, that, for example, say there's a telehealth session scheduled with a patient, just A, the connectivity, B, the staff in a situation that's still chronically understaffed, and being able to have an actual really excellent visit can be challenging when that team member needs to be all over the place. And that's, again, a important question for how to devise these, and sort of, I guess we won't call it the post-COVID era, but the other side of the COVID mountain, if you will. Like, how do we sort of reorient our strategies? And I think staffing has got to be a critical component. There needs to be members on site, if it's a facility or other populations that are capable of doing that. And I'll say, for our home care program, we have a home-based primary care program where we have fully integrated telehealth during the COVID era. At our institution. And that's one of the things we've really focused on, is working with caregivers, particularly for homebound older adults, to help them feel like they are able to use the technology and ready to use the technology. And to Kim's point about connectivity, working really hard on the connectivity challenges that we continue to face.
Just to speak to kind of the clinical areas where this could be used, as we were deploying devices, there were several clinical specialists at UVA that had patients that they were following for specialty care, whether that was wound care or cardiovascular. There were patients who were post-op. There were some of these facilities are rehab facilities that patients go to for shorter term care during their rehab time. And they were, the specialists were kind of excited to hear that there was a way to connect with their patients in the facility and not have to bring them in for post-op visits, for check-ins that didn't necessarily require a hands-on visit, but that we could use the telehealth technology to do a full physical exam, or they could just kind of chat with their patient on screen and get an idea for how they were doing, using something as simple as a tablet. So that was something that we sort of realized would potentially be an opportunity to expand the use of these devices in the facilities after the needs related to COVID were no longer an issue, but also that those needs didn't go away just because there was a virus. There were still patients that needed wound care and still patients that needed to see specialists. So there was never a break in the care, the need for care. We just were able to kind of speed up the process with getting these devices deployed because of the outbreak situations at some of these facilities.
If you can, and without us sounding like a commercial for any particular company, just know, folks, if you're listening, that every device, every technology, that piece of technology that you use comes with pros and cons, and it needs to fit your use case. So with that kind of disclaimer, several folks, I think Marcia and Mindy may have asked, like, tell us about the kit, like what it contained.
I can speak to that. So we deployed, the kit had an iPad. We used the TytoCare device for the peripheral, which allowed us to listen to heart and lung sounds, and then also it has an otoscope capability. I think we used it once as the needs were more respiratory and cardio based. And I guess probably Justin and then our critical care pulmonologist and Lori as well, if you've kind of listened to and had the output, been able to hear the device itself, can sort of speak to what the primary uses were for that. But we often, most of the assessment could be done just on screen with the iPad. So though we had the peripheral, we're not, even to train people on that wasn't necessarily the thing that they ended up needing to use. Justin, Laurie, I'll defer to you from the clinical side.
Yeah, we, as Kim mentioned, the peripheral that we used was TidoCare, and much of the visit, well, any geriatric care really, or any often medicine-based visits, 80% is history, and often 20% is physical exam. And so getting a great history, a great understanding what's going on was most important. And then we could also use the device to listen to the heart, listen to the lung sounds, to be able to track changes or any sort of wheezing or whatever physical exam finding we may have.
Well, we have enough time for just a quick round robin answer session. If you would think about like every organization that you worked with in accomplishing this, could you name like one thing like that from an administrative perspective, like what are the key steps that the administrators can do to help you in these efforts?
I'll go first. I would say kind of like a key or a marker of success when we would work with a institution or a good relationship would be open-mindedness, right? Just being open to trying something new, to being able to implement innovation, and to be open, in new situations, to be able to deploy new processes and new systems, with obviously a full disclosure and open understanding of, hey, if it doesn't work, let's not just keep with it, to be able to evaluate how things are going, but to have open and honest communication about needs that are there, and to be open to exploring new ways of doing great care.
And Justin, if you want to throw in a word, and Kim, we're at the very last minute, and then I have to ask our AV to put up the last slide, and we'll close out.
Yeah, I would just say, kind of drawing off of what Laurie said, dedication to the process, but a process that is adaptable, but really sort of seeing it through, because toward the end, I think everybody was feeling like, so glad we did this. We went through these hard steps.
And my piece would be listen to the nurses, the people on the ground, the people at the bedside. And if they tell you it's too much, if telemedicine is going to slow down their care delivery, it's not the right solution. But I think that's key. They're nursing homes. Listen to the nurses. They can tell you a lot that you can guess at when you're building a protocol, but that you could have fixed if you had listened to both sides of the story. So that's my advocacy for my nurses out there.
Well, thank you very much. So folks, hang in there just for another 30 seconds. Please provide session feedback. I'd like to thank the panelists, and we hope that you enjoyed and that you're energized from the learnings and the exchange of ideas and how to advance these care miles that help our older population. I encourage you all to continue this dialogue. It's not just a COVID thing. Please reach out to any one of us for further information. Look for our email, follow us on Twitter, and know that no matter what Zoom session you go on to after this, you are always going to be disappointed. On behalf of each presenter, myself, and Matrix, thank you for joining us. Have a great day.